Hello everyone, this is Dr. Sultan Moinuddin Shaukat Ali. I've completed my MBBS, MD and DNB in radio diagnosis from State GSMC and KM Hospital, Mumbai. I am here to teach you thyroid ultrasound. Before this, we have seen various other ultrasounds, modalities, techniques, the methods of diagnosis, the image findings. In this session of today's, we are going to discuss about few congenital thyroid anomalies, few congenital thyroid disorders, and the image findings. That is basically the ultrasound findings in these patients. Okay, so basically, thyroid is one such gland which can also be associated with multiple anomalies. Okay, now let us start with the topic. So, just like as usual, we often start with the fundamentals, the basics. In this topic also, I would begin with the basics of thyroid so that it becomes very easy to understand. Okay? Now, you know that the head and neck structures, they develop from pharyngeal arches and pharyngeal pouch. Okay? Embryology wise, all the head and neck structures, they develop from pharyngeal arches. Correct? Pharyngeal arches. So even thyroid develops from pharyngeal arches. Okay. Now, when it comes to the development, this is the thyroid gland, the isthmus, the right lobe, and the left lobe. The congenital anomalies like complete agenesis. If there is complete agenesis, you would see that there is no thyroid gland at all. So you look it in the neck region, okay, you scan it throughout and there is no thyroid gland, okay. Of course, in this patient, the T3, T4 will not be there. So it would be very, very low, okay, because there is no thyroid gland to synthesize these hormones, and the TSH would go high as a negative feedback mechanism. Okay? That is complete agenesis of thyroid gland. Second important congenital anomaly which you may have is partial agenesis. So you might find that the half, that is either the right lobe or the left lobe, is absent congenitally. So often when you are doing an ultrasound of neck and you find that a lobe is missing, the next important question which you need to ask is history of surgery. In case if the lobe is missing, not there, correct? So the next history you ask is any history of surgery. So suppose the patient tells you that he or she did not undergo any surgery. So in this case, the next thing which you would think of is congenital partial agenesis. Partial agenesis. So these are the important things which we have discussed. That is, complete thyroid may be absent, although rare, but can be a possibility. Second is partial agenesis, in which a particular lobe might be absent. Third important congenital anomaly which you might find in patient is presence of pyramidal lobe. So there can be an extra lobe like this in this region of the isthmus, and this lobe is called pyramidal lobe. Pyramidal lobe. Okay, these are few anomalies which you see. Now there are other anomalies like which are most important. These are all easy to diagnose: complete agenesis or partial agenesis or pyramidal lobe. But there are other anomalies like patient might have ectopic thyroid gland. This is commonly seen when you don't have a thyroid gland in the neck. You should Next thing is you should look for what is called ectopic thyroid gland. What do we mean by ectopic thyroid? You should look it along the path of embryological descent, that is from neck till the midline where you have isthmus. In between that, you anywhere you can have the thyroid gland, and that is ectopic tissue of thyroid gland. Okay, so that is also a common finding which often you get in young patients. Sometimes you get elderly patients. Like I had a patient, एक बार एक patient आया था जिसे there was a swelling in the submandibular region, a large swelling, and he was complaining that there is a swelling over here, and they were about to, the surgeons were about to, remove out that swelling. But before that, we went for an ultrasound, and on ultrasound, we found out that that swelling which he was complaining of is actually the only thyroid, ectopic thyroid tissue which is present in his body, because his normal thyroid gland was absent. So there was a complete agenesis of thyroid gland in his neck region, and there was an ectopic thyroid tissue in the submandibular area. So sometimes you have ectopic thyroid tissue also. Another important congenital anomaly is another congenital disorder is presence of thyroglossal. As the name suggests, thyroglossal. So it's connected to thyroid, and glossa means tongue. So it is connected to tongue and thyroid gland. Thyroglossal duct, it forms thyroglossal fistula or thyroglossal cyst. So you can have a so there is the normal thyroglossal duct through which the normal thyroid descends down, and there is formation of thyroid. Later on in adult stage, that is after post-fetal stage, it is supposed to close, but sometimes it doesn't close, it remains there and leads to formation of thyroglossal fistula, or sometimes there might be cyst formation, that is in the form of thyroglossal cyst. Okay, so these are the important pathologies which you need to keep in your brain when it comes to imaging thyroid disorders, especially in children, and midline swellings in children. Okay, that is congenital thyroid anomalies. So in this session, I'll discuss the most important congenital anomalies. One of them is the thyroglossal cyst. So this is again a congenital condition we have discussed. So during embryogenesis, we should know that the thyroid gland tissue, it migrates from foraminous cecum of the tongue to the lower neck. So if you see the embryology, you should know this, that there is tongue superiorly. In the tongue, there is a special foramen which is called foramen cecum. Thyroid tissue migrates from foramen cecum of the tongue down into the neck region and later on forms thyroid gland. Sometimes this canal through which the migration occurs, this is called thyroglossal duct. It might remain there. So leaving behind an epithelial tract, and this tract is called thyroglossal duct. Okay, thyroglossal duct. Now cell remains in thyroglossal duct in some cases may give rise to cyst. If it gives rise to cyst, this is called thyroglossal cyst. Or sometimes the entire thyroglossal duct might remain patent and might open in midline of the neck. This is called thyroglossal fistula. So it has to be typically in midline between thyroid bone and hyoid bone. So in between them there is a hyoid bone here. Okay. Thyroid and hyoid के बीच में there is a midline swelling. How do you confirm that this is a thyroglossal cyst? Simple. There is a tongue protruding sign. So you ask the patient to open his mouth and protrude the tongue. Extend the neck, protrude the tongue. This is what you ask the patient to do. And if you see that swelling moves up and down with movement of the tongue, then that is a very important positive tongue sign. So that is very classical of thyroglossal cyst. Okay, thyroglossal cysts moves on movement of the tongue. Okay, now we'll see the ultrasound image of thyroglossal cyst. And before we come to ultrasound image, I'll be showing you the clinical image when to think of uh, thyroglossal cyst. So here in this patient, we had a midline neck swelling. You can clearly see this is the midline neck swelling, and this was showing movement on tongue protrusion. So if you move tongue, this was also moving up and down. Okay. So that means we diagnose this clinically as thyroglossal cyst. I'll be showing you the ultrasound image too. Now, in this image, I've shown you the pathway of embryonic thyroid gland. That is, you are able to see this is the region of foramen cecum. This is the region of foramen cecum and of the tongue. And then you can see that this is the migratory pathway through which the thyroid glands migrates downward. Now, if anywhere along this is called thyroglossal duct. Anywhere along this, the epithelial remnants might give rise to cysts. So anywhere that is subhyoid region or in this below hyoid region or pretracheal region, prelaryngeal region, you can get uh, thyroglossal cysts. Okay. Now I'll show you the ultrasound image of this. So look here, this is how we see. So you can clearly see that there is a well-defined anechoic, that is completely dark, cystic. How do we confirm that it is cyst? Number one, it is anechoic and completely dark. And can you see the posterior acoustic enhancement? If you compare it with this area is very bright. This is posterior acoustic enhancement. So this is a cyst. Okay, so this is a cyst. So this is how we confirm that this is a thyroglossal cyst. Now again look here. This is the cyst. Okay, and this is the normal thyroid gland. And these are the tracheal rings. Again here in this case B, you can see that this is the thyroglossal cyst. Okay, this is the thyroglossal cyst. The infrahyoid region. So this is hyoid bone. This is panoramic view. This is tracheal cartilages. This is trachea. This is posterior acoustic enhancement of the cyst. And you can clearly see this. This is thyroid gland. This is thyroid glands. So you can clearly see that there is a well-defined anechoic cystic lesion in subhyoid area just below the thyroid gland in midline, which is moving on protrusion of the tongue. So this is very classic of thyroglossal cyst, thyroglossal duct cyst. Okay. Now, these are other examples of thyroglossal duct cysts. So normally you might find that the cyst is clear, but in some cases you might find that the thyroglossal duct cyst might show colloid material within it. Like in this case, you are able to see that there is a thyroglossal duct cyst with multiple comet tail artifacts within it. Here you are able to see the cyst with a solid debris within it. Again, here you are able to see the cyst and there are few septae within it. Here you are able to see a pyramid line, well defined anechoic cyst just above the larynx. So you can see that this is thyroid cartilage. This is thyroid cartilage. Okay, so sometimes this can also be the position of thyroglossal cyst. Here again you are able to see the cyst with all colloid material within the cyst. Sometimes you find microcalcification. So whenever you have microcalcification, very important, this can be papillary carcinoma of thyroid. So very important. So whenever you have the changes, long-standing changes in the uh, thyroglossal cyst might give rise to papillary carcinoma of thyroid is a very important papillary carcinoma from that cyst. Similarly, in this case, you see that this is the thyroglossal cyst, but it has developed all heterogeneous, solid papillary-like areas within it. This on FNSC turned out to be squamous cell CA. So whenever you have solid components within the thyroglossal cyst, always go for FNSA or biopsy. That is must, okay, because there are chances that it might undergo malignant transformation into papillary CA or squamous cell CA. So this was about thyroglossal duct cyst. Now we come to the next important topic, which is ectopic thyroid gland. So what do you mean by ectopic? We have seen the meaning, that is abnormal anatomical position of thyroid. And what is the most common location? Again, midline suprahyoid position, that is called lingual thyroid. Just we have seen the migration of thyroid from, if this is tongue, we have seen that there is a foraminous cecum region from where it migrates down to the actual thyroid region of the neck. In between there lies a hyoid bone. Here, here lies the hyoid bone, right? So this is the site of migration. This is the pathway of migration, which is called thyroglossal duct. Now, anywhere along this duct, you can have ectopic thyroid. So if you have it in suprahyoid region in tongue, we call it as lingual thyroid, which is one of the most common location. Then you can have it sublingual or in the region of larynx, which is called paralaryngeal. Sometimes you can have intratracheal or infrasternal ectopic thyroids also. Okay, so that is one important finding. And remember that even in ectopic thyroid, it can suffer from all those pathologies which occurs in normal thyroid. So like colloid nodule or enlargement, thyroiditis, all this can take place also in ectopic thyroid. Okay, sometimes patient can present with a tongue swelling, and that is a ectopic thyroid on the posterior aspect of tongue. So now let us see this. So if you see here, there are four important images which I have discussed. So if you see image A, image A, this is again a transverse section. Okay, this is a transverse section, and what you are able to see is this is trachea, here is trachea, and this is esophagus. This is esophagus. So this is tracheoesophageal groove between trachea and esophagus. So here we should have seen the thyroid gland in this location, but it is not seen. That means thyroid gland is absent. Thyroid gland is not there here. So thyroid gland is not there. Similarly, if you see the left lobe, you are able to see that in the same patient, so you are able to see that this is trachea, and you are able to see that in this region there is some thyroid like material, but no much uh, proper visible thyroid tissue which is seen. So again, it is either hypoplastic or it is absent, and this is carotid artery. So in the same patient, when we look above, that is in the suprahyoid region, okay, there is a midline neck swelling. So you can see that this is larynx, this is the thyroid cartilage of larynx, this is thyroid cartilage, okay. And pre-laryngeal, we have got a well defined homogeneous hyperechoic structure. Okay, you are able to see this in the pre-laryngeal region. So this is nothing but this is ectopic thyroid. Ectopic. Okay, so hope this clears for you the two main pathologies what you see, that is congenital absence of thyroid, hypoplastic thyroid. Then we have seen about ectopic thyroid and thyroglossal cysts. Most importantly, we should also look for malignant transformation in long-standing thyroglossal cysts into papillary CA or squamous cell CA. Okay, so with this I end my session. I advise you and will be very happy to see your comments, to see your feedbacks. So your feedbacks, comments are most welcome. Whatever queries you have, you can definitely put them in the comment section, in the chat box, in the query section, and we'll be happy to, you know, to send to hear from you, to help you out what more you need, and we'll be planning accordingly. Okay? Thank you.